That leads us up to the panel discussion. So for this, I would invite Andrew and James and Emma and Krista to turn on their cameras because I'm going to be asking some questions. So James, a question for you. I think this one, you would be good at answering this one. The question is there good evidence that exercising whilst fasting has beneficial effects for fat oxidation, weight loss, or other metabolic benefits compared to the fed state?
Yes, so we had a paper published on this in the last year or so, led by my colleague, Dr. Javier Gonzalez. And in that paper, we showed that if people spent a number of weeks performing morning exercise, either before or after their first meal of the day, that if you did that exercise before, so in the fasted state, then you do indeed oxidize more lipid. You therefore get to clear more lipid from in muscle tissue. And then we demonstrate through that the metabolic response to feeding can be improved. Specifically, people are more insulin sensitive. So that's one of those examples, I think, where if we try and perform some exercise in the fasted state, then you can maximize the benefit that you've invested in doing that exercise.
Great, okay.
Can I just ask James as an add-on, does it matter what gender it is, if you're male or female?
In these studies, when we're taking the kind of muscle samples and so on, we've tended to just test males as the first step, which I think is something we definitely need to move on from. But at the same time, I can understand why that's normally the first step, because if we want to test a smaller sample size, then you test the males because you haven't then got to consider the complexities of the menstrual cycle. Whereas then when we see these effects, we extend the studies and test females later. So I definitely think that when we're talking about fat oxidation, that is a variable where we know that to do with fat oxidation and insulin sensitivity, there are sex differences. So those studies do need to be repeated in females only too.
Thank you for the follow-up, that was interesting. So Krista, a question for you, which is whether the intermittent fasting is particularly effective for different chronotypes, meaning those that are more morning birds or evening larks. So maybe you could tell us a little bit about that, please.
So we've only started using the morningness eveningness questionnaire in this last long-term study to even evaluate whether or not people are more morning or evening. So again, a great question, but we won't have data on that. We didn't collect that in any of our previous studies, so we're not quite sure just yet. But we should have answers in the next year or so.
Yeah, maybe you can tell the audience a little bit about what we mean by the term chronotype then.
Oh, sure. So a chronotype is basically whether you tend to be kind of more, from my understanding, I'm not like a sleep scientist, but kind of if you tend to go to sleep a lot later and have more energy later into the day versus if you're a morning chronotype where you're literally more of a morning person. So if you were to do this questionnaire, a lot of the things that it asks is oh, if you had to go for a run, would 7 a.m. be good for you, or would 10 p.m. be more ideal? So it's trying to figure out if you're, do you go to sleep at 2 a.m. or do you go to sleep at, 9 p.m. and wake up at 5 a.m. in the morning. So really kind of are you a morning person versus a late night person?
Great, okay, thank you. This is a question for Emma. So in practice, should healthy eating advice be included to ensure nutritional adequacy?
It's a good question. It depends what your aim is, really. I suppose that comes from my comment that bearing in mind you're restricting what you're eating, that your nutritional adequacy might also be impacted. I think that comes down to the same question you would have if you were a dietitian or a healthcare professional and having a consultation with somebody about their diet in general anyway. Ideally, you'd want to know what their nutritional status was and see if you could improve it. It depends what the priority is. Is the priority that they want to try and lose weight or improve their weight loss maintenance? In an ideal world, which doesn't actually exist, you probably want to do all of them. But in practicality sense, it may be that for motivation purposes, if somebody's had a strict regime and they've lost weight, that perhaps just discussing time-restricted feeding is the first step, and then look at nutritional adequacy. Certainly, if they're looking at any form of diet for an extended period of time, it's worth looking at nutritional status there. Okay,
great, thank you, that's good. This is a question for Leonie that I'm going to answer, and the question is whether bedtime is an important consideration for appetite control. So I think this is really interesting, because often when I talk about the scenario of having a big breakfast and a smaller evening meal, which is like breakfast like a king and dine like a pauper, then people sort of roll their eyeballs and say, no, I couldn't possibly eat breakfast. And then I say to them, well, you know, what time do you stop eating? And often these are people who are eating late and are therefore not in a position to feel hungry first thing in the morning. So I think the big breakfast data that Leonie presented is in conjunction with a smaller evening meal. So the two sort of go hand in hand there. So yeah, that's a great question. Next question, there's one for you, Andrew, here. So a question is, how can patients be more involved in research?
I think the way to do that is to engage with them, to be honest with you. The more that you can speak to a patient and get the patient perspective, I feel the more you're going to kind of learn from that. I think it helps to get the patient perspective to tailor any approach that you can take as well. From my point of view and the patient perspective point of view, language is kind of an important factor to it as well. And the way that you kind of speak to somebody who may be living with obesity. At the end of the day, we are a patient. We are not obese. We are somebody who is living with obesity, and I think that's really important to kind of get that point across in any paper that is in any research that is kind of conducted, to engage with us and treat us as a person, not as a kind of subject.
Great. Okay. And can you tell us a bit about the association that you work with then, Andrew? Just give it a quick plug. Yes.
Absolutely, yes. So I am the Director of Communications for the European Association of People who are Living with Obesity. So we represent individual organisations on a number, I think we're up at like, I can't remember the number of European countries that we're actually representing just now. But we are the kind of face for these companies, and we kind of pass their message on to each individual representative within their country.
Great. Is there a website we can have a look at afterwards? So.
There is indeed, yes. So the website for ourselves is www.eurobesity. So that's EUROBESITY.org.
Okay, great. Thank you. There's a question on whether, for any of the panellists, whether they're aware of any studies on the use of time-restricted feeding for children or adolescents living with obesity, and would their results be different for children, and would there be any different safety considerations? Maybe Krista, you could comment on that first.
To my knowledge, there's nothing for time-restricted feeding, but there is a study going on in Australia at the University of Sydney for alternate day fasting in teenagers. So I think the age range is 13 to 18 with severe obesity. And they published a pilot study showing that alternate day fasting does work in that group with obesity. And now this is like an extension of that. So it's a year-long trial. There's been a lot of pushback with that though, just because of propensity to develop eating disorders in teenage years. That's usually when like people first develop eating disorders. So their study was actually stopped several times by eating disorders associations, and it's been tricky. I'm one of the co-investigators on that, but that's the only study I know so far testing intermittent fasting in teenagers.
Good. Okay. James, one for you. I can see in the chat that there was discussion about, there was a discrepancy in the definition of different diets to do with time-restricted feeding and intermittent fasting. And obviously some of that perhaps is a cultural aspect, in that the terms are used perhaps differently between the US and the UK. Do you want to comment on that, the importance of defining what we mean by timing of eating?
Yeah, I found that very interesting, hearing about, I wouldn't say it's a kind of difference of opinion, but these subtle differences between whether time-restricted feeding is mutually exclusive from intermittent fasting, or whether it comes under the heading. And I see that presented in both ways, even in the scientific literature. And so in some ways, I feel it's important to come to an understanding so the public can be given this clear message of this is what you're doing. But then in the scientific work, I wonder whether some forms of time-restricted feeding might differ from one another more than they do from alternate day fasting, or what we might call intermittent fasting. So I'm always in two minds whether we need a definition, and perhaps that's from kind of my background looking at breakfast, because we're constantly arguing about what a definition of breakfast is. And I think if the scientists manage to define it, we'll just end up with all of our studies very, very thoroughly understanding just one definition of the word breakfast, and anyone following a different definition, the research wouldn't apply.
Yeah, no, I agree. It's important to define the context of time of eating as a whole day, actually, not just one period of time. So I think that's a valuable point. Thank you. Andrew, can I come back to you, please? So there's a question about whether you use any tools to record your eating patterns, whether there's any insights that you have there. So how would patients go about what would be something you've heard that is used commonly?
So I think the most common that I have used and that I've heard of to record food and eating patterns is the likes of MyFitnessPal, things that are easy to record on. So the apps that have got a barcode scanner that you can scan what it is you're eating, and it automatically tells you what the calories are in it. You can record that against breakfast time, lunchtime, dinner time, so it allows you to kind of keep track during the day as to what you're eating as well. And that's got to be one of the kind of better ones that I've come across.
Yeah. I think it's an interesting question, isn't it? It's about tools that make it easier to comply with the diet, because after all, any diet will work, won't it, if you can comply to it. That's
absolutely, yes. So as long as you can comply with it, and that's the kind of most important thing. It's been able to overcome the demons that are in your head that are telling you what you have always been used to. And it is just a case of giving you the tools that will support you get over that initial time period that breaks the cycle that you have been stuck into for that period of time that's the hardest, I feel.
Yeah, great. Okay. Krista, if I can come back to you with another specific question, is there any thoughts on the relationship between migraines and obesity? And the person that submitted it said, I see there are studies to show it can be linked. That's not something I'm familiar with. Is that something you've come across?
I'm sorry, with migraines and obesity?
Yes.
I don't know much about that field. I don't really do much like neuroscience work. I'm sorry about that.
Okay, no, it's not something I'm familiar with. So, okay, moving on. I think this question would be good for you to comment on, Krista, then. When do you imagine that intermittent fasting will be trialled being used by dietitians with patients for weight loss, as part of the clinical care system?
So the question is, when do I think it will be incorporated?
Yes.
Sorry, I can't speak for the UK, but I know in the US it's being incorporated into like the American Diabetes Association guidelines. It's already there. Same with I believe, who else's guidelines? it's not in our like obesity guidelines just yet, but they only update those like every 15 years. So hopefully in like 5 years when they come up with the new ones, they'll put it in there. But I do have to say though, it's been kind of frustrating studying in this field. Like I've actually been trying to get like long-term studies of time restricted feeding funded for like the past 12 years, and reviewers have always been like, nobody cares about this. And now we don't have any data when actually people want it. And, you know, luckily we're getting something funded for long-term so we can incorporate it into guidelines. But I think I don't know, the scientific bodies have been kind of clueless as to what the general public wants. And it's been hard to generate meaningful science in this field because of that. So sorry, I just had to mention that. And I think that's what's slowing down getting these into guidelines, etc.
Emma, do you want to follow up on that from a UK perspective?
Sure, from anecdotally from clinical practice, we would use this as a person-centered approach. So most likely if a person comes into a consultation and wants advice, they probably already have the best idea about what they want to try. And as Andrew mentioned, this is cyclical, so people have always tried something else, they've tried something before, and in the person-centered approach, if they feel it might help them, then it's our job to support them through that. So we would absolutely support people to attempt any form of restricted diet. Going back to the point about nutritional adequacy, if they're going to find to follow any sort of diet for any long period, then it's our job to support that, to ensure that they maintain their health during that process. But Andrew, I'd be interested to know, in terms of your experiences, sort of the cyclical approach to approaches to energy restriction or to attempting weight loss, and where this might fit in terms of, you know, your appreciation of other formats.
So for that, I'm not too sure, to be honest with you, is the kind of right answer. It's something that I've never tried before, so I'm always willing to try something new. But I think with anything, it's if you plan it right, it will work well. So anything that you try new, you need to plan out how you're going to actually do it and how you're going to achieve the end goal, essentially. But that's all I can really answer for that, I'm afraid.
Okay. James, this is a question for you. The question is there any effect of early morning exercise linked to circadian rhythm rather than the fasting state per se?
I'm not certain I understood the question fully there. Certainly, the timing of exercise can have an effect on the circadian rhythm. Are we saying independent of fasting, I suppose? So irrespective of when you eat. So I think part of that rhythm, there are signals elicited by exercise which would be there no matter if you exercised in the fed or fasted state. So certainly exercise has the potential to impact circadian rhythms. The big question, which is why I think we need to look at the interaction between exercise and meal patterns, is whether we can either accentuate or attenuate the response to exercise as we would need to. So whether you want to get more of a stimulus to adjust your circadian rhythms. For example, if you exercise in the morning without breakfast, does that larger signal that the exercise then carries have more potential to set your circadian rhythm and align all of the metabolic responses in a day? But we just don't have the data on that yet. The circadian rhythm kind of people and the exercise people have only recently kind of come together to look at these things.
Yeah. Maybe can you just briefly describe what you mean by circadian rhythm then, James?
Yeah, so that when most people talk about circadian rhythms, they mean that there's certain patterns in our body, both in our metabolism, the stuff you can't see, and in our behavior, as we've heard, when you choose to eat and sleep and so on. And these are set to approximately a 24-hour rhythm because throughout evolution and throughout our individual lives, we've become accustomed in most countries to a light-dark cycle with day and night. And so our body doesn't just react to that, it anticipates that. So when you wake up in the morning, you've already got your testosterone and cortisol reaching the appropriate levels to start your day. And so then this has been of interest in health research, because if you get that wrong and do shift work or eat at night or look at your phone all night with light on in your eyes at 2 o'clock in the morning, it's then misaligning those rhythms. So your body's anticipating food and exercise at the wrong times.
Great, okay, that was really useful, thank you. So Emma, are you familiar with ketogenic diets? There's a question, has anyone looked at the use of low carb and intermittent fasting without necessarily going into ketosis? Might this improve insulin resistance and inflammatory markers? And maybe I can add to that, independent of weight loss. Then, so that's a complicated question.
It's an interesting question. I would refer people to the evidence base around reducing carbohydrate in terms of the outcomes for that in terms of weight loss. And if you're somebody who has type 2 diabetes in terms of management of glucose control, so if you have a lot of carbohydrate in your diet and you manage that carbohydrate load, then it will inevitably improve your glucose control, and it should also improve, if you're restricting your calories through any restriction, including carbohydrate, you will also improve your weight. So that's separate. If you then look at the question in terms of restricted time eating, I'm not sure, I'm sure Krista will be able to answer this, if there are any studies at the moment that specifically look at reducing carbohydrate as a macronutrient in that particular feeding window.
We just published a study last year where we combined alternate day fasting with a low carbohydrate diet. And we did find that it actually boosted weight loss a little bit. So typically after 3 months, you'd see like 5% weight loss, and we saw like closer to 7%. And then we also saw slightly greater decreases in insulin resistance as well, and fasting insulin levels. But we haven't combined that with time restricted feeding yet, no.
Yeah. So Krista, this is a question specifically linked to your talk theme. So this is a question from a person who's lived with obesity since childhood, and the question is, are there any risks for the person who is morbidly obese if undertaken any of these approaches to weight loss? So what's the main risks for somebody who's morbidly obese?
I'm not sure. We haven't done, most of our BMI ranges have been like 30 to 45. So we haven't done many or really any studies in morbidly obese, but I think an issue is with weight loss with morbidly obese is gallstones can happen if there's like very, very low calorie diets. I don't think, because the dietary restriction with time restricted feeding is only like, 300 to 500 calories per day, I don't think that could occur. I'm not sure. Yeah. Does anyone else who works with that population group have any, Emma, or I'm not sure?
We certainly have looked at low energy diets and very low energy diets. And although there is a theoretical risk in terms of a transient effect, in fact, we're hoping to publish a paper looking at adverse events or lack of adverse events in low energy diets. And of course, where we're at the moment with the NHS pilot of low energy diets in this country in 10 geographical locations. So in that respect, not, as far as I'm aware, an issue in terms of, as Krista said, because of the energy restriction level, in terms of restricted time eating is much less than you would see in something like a low energy diet. In terms of the management of medications, that's something that maybe needs to be considered, and I think something that Krista could probably comment on as well, because in terms of if you're having, say, type 2 diabetes, glucose regulating medications, you would need to have that considered, or indeed blood pressure medications, you need to have that considered. If you were looking at your eating window changing and how that might impact your intake and also your medication management.
Yeah, that's a great point. We actually screen out people for our time restricted feeding studies that need to take medications with, like in the morning, and then sometimes we don't have the eating window in the morning. So we do screen those people out. And in general, though, I would say anyone with type 2 diabetes that wants to do intermittent fasting or any of these like meal timing changes really need to work with their endocrinologist, because it can become very, deadly if you're messing with your glucose and insulin levels and those medications. There's only been one study that's actually looked at type 2 diabetics, and they found that it helped, but those people, they ran the risk for developing hypoglycemia. So they just recommended people to work with their doctors. Absolutely.
Okay. Just want to check in with Anne. That's us down to the last 5 minutes. Are you wanting us to finish off now, and you want to make sure that we finish on time?
Yeah, can do if there are no more questions, but there could be time for one more question to answer.
Well, there was one here I thought Andrew maybe wanted to comment on, and that's really about yo-yo dieting. We haven't really touched on that, and about the issue of weight regain, sort of going from sort of the mindset of sort of dieting and then trying to keep weight maintenance. Is that something that the patient group are keen to discuss, just in terms of thinking about future topics as well?
Yeah, absolutely. From the patient groups, regain is a real concern. If you haven't had regain yourself, you're going to know somebody who has had regain. I think what is important to help prevent that is ongoing support, both professionally and kind of peer-to-peer support too. Keeping in with those type of support groups is crucial.
Okay, no, yeah, I think that addresses the comment that was made. That's great. Okay. So I want to open it up. Do any of the panel want to make any last comments that we feel we haven't covered? And I mean, the discussion has been very broad and wide-ranging. It's been really, I've really enjoyed it. So is there anything that you wanted specifically to cover that we haven't covered? No, all nods. Everybody looks happy. Okay, over to you then, Anne.